So we'd like to bring our next panel up, and I'd like to introduce the gentleman who put the Connor in Pierro, Connor, and Strauss, my partner, Aaron Connor, who is going to chair the next panel. Aaron heads up our litigation department. He also heads up our long-term care planning department, and he's been an integral part of the firm in the courtroom and out, does guardianship, estate and trust litigation, will and trust contests. But today he's going to put on his long-term care hat. Do we want the seats?
I would think seats probably.
And you want to pull this? You're going to stand. Okay. And we have put together for you, if all the panelists would come up, Aaron's going to introduce you, but we don't have the smoke and lights. So just come on up and take your chairs. And this is a panel that really gets to the heart of the matter, the holy grail, which is finding a home health aide and making sure you can pay them and sustain a home health care program. So with that, Aaron.
All right. Thank you, everybody. I think we all know, and I agree with Greg. I don't know who those 1.5 people are who don't want to age in their home. To date, I only ever had one client tell me that she wanted to go to a nursing home, and that's thousands of people. So her alternative, though, was to live with her son's husband as well, or son's mother. So we tried to get them both together, both in-laws, and she's like, no, I'd rather go to a nursing home. So we tried. But we are missing one. All right.
Where is Alicia?
We'll save Alicia's introduction for last then, I guess. But Valerie is here, so if you missed Valerie speaking earlier, shame on you. Always great information and things hot off the presses and things that we very much need to know, because as these things change, they don't get easier to accomplish. So Valerie is still associated with NYLAG?
Yes.
Okay. And she is certainly the fierce advocate for access and home care services. She's received many awards, including the David Veach Advocacy Award for a passion for advocacy for individuals with all types of disabilities, and President's NAILA Award. And she's also been a member of the Executive Committee of the New York State Bar Association for Elder Law and Special Needs. And the first of our two Andrews, not in any particular order, but we have Andrew Koski, who is the Vice President of Public Policy and Services for the Home Care Association of New York, who's probably a little fired up with what he's heard so far today. But with 20 years at the Home Care Association, Andrew monitors local, state, and federal changes in Medicare, Medicaid, and other programs impacting home care providers. He authors alerts and the Situation Report newsletter for HCA members. He's provided updates to regulatory changes on Medicare and supplemental Medicaid insurance, or Medicare insurance, excuse me. He leads the Home Care Association of New York's emergency preparedness efforts in New York City and statewide. And Andrew DeLolo, Director of Financial Planning and Analysis for Consumer-Directed Choices. Very important agency. He has a foundation background in public health. Andrew's career in healthcare and administration has focused on serving those in need. In his current role, he provides strategic direction for the Consumer-Directed Choices financial planning, monitoring, evaluation, and reporting. He advances the organization's mission by identifying and obtaining and managing grant opportunities. Prior to Consumer-Directed Choices, Andrew served as the executive director of the Marjorie Doyle Rockwell Center in Cohoes. And we also have Alicia Kelly from Vice President of Government Programs at CDPHP. Alicia joined CDPHP in 2005 from the Healthy Capital District Initiative, assisting individuals and families with obtaining health care coverage. At CDPHP, she is currently responsible for growth, retention, and operations for the plan's Medicare, state programs, and individual lines of business. Alicia is active in the community and supports on several boards. Are you a Yankees or a Red Sox fan? Okay, then I can read this. Alicia also attended the first Major League Baseball game in Europe, where the Yankees prevailed, and that's really all we need to know about that. So, what are we talking about? Well, like we said, everybody wants to stay home, but how do you do it, right? There's a lot of things that need to be thought about: suitability of your home, how you're going to pay people, who you're going to have. And last year, we put this in practice, right? So we talk about things kind of in the abstract, but they're really not you don't get the real feel for it unless you see what it affects an individual. And we had a great individual, Stan, who was disabled, had worked his life, had a plan, he was going to stay in his house, the family house that's been there for a long time. He had saved some money so he would be able to offset some of his costs, but when it came time for assessment, he was only given very few hours, 4 or 5, I can't remember. But he appealed that, and he got 1 extra hour a day. You know what, we were wrong. Sorry, 1 extra hour, which wasn't even close to what he needed. After a fair hearing, he was able to get what he should have had initially, which was 24/7 home care. And then he kind of went to bat for himself, as he had been an advocate of, and got reimbursement, which is not provided for unless you can get an act of the New York State Legislature. So we wanted to give you an update for Stan, and Beth Wortman of our office created this video. So let's give it a roll.
One, two, three, and up.
Stanley DeZark had already waged a legal campaign and won. A retired accountant with the state tax department, he proved that a managed long-term care plan had made an error when awarding him a mere 5 hours of home care a day instead of the 16 hours his doctors said he needed, paid for by Medicaid. But winning his legal case with the help of an attorney and care manager had taken a lot of money and time.
8.5 months. But I had paid out of pocket
To the tune of how much?
to $68,615.
Stanley wanted that money back, more than $68,000 he personally dished out for 10 hours of home care each day while his case dragged on in appeals and a fair hearing. Armed with legal documents, he started faxing the managed long-term care plan, demanding to be reimbursed. After 8 attempts and no response, Stan contacted his state assembly member, who stepped in to break down barriers.
Stan's background prepared him for this challenge with his healthcare provider as it relates to attaining reimbursement from his health plan. His tenacity is unparalleled, which has led to his successful outcome.
The MLTC did respond, the first check totaling more than $66,000, and eventually the grand total. Stan had triumphed for the second time.
But when I finally got the check, I felt very happy that I had proven my point.
All right, you ready? Okay.
His point, Stanley hopes, could set a precedent for other Medicaid recipients who challenge an MLTC. He achieved his goal to age in his own home with the kind of determination not everyone can muster.
Stan is an exception. I worry for those patients who do not have the background and tenacity of Stan, and it is critical that all patients are treated fairly.
All right, thank you, Beth. So just to be clear, this is an extreme outlier of a case for him to get his reimbursement. So there is not a statute that allows for that generally. So if you want it, you got to be your own advocate, and you got to have a really responsive legislator, which Stan was very fortunate to do. But when we want to stay at home, we want to know what's available to us. And one of the things that people miss are things that are available in their Medicare program, and Alicia is going to talk about this.
All right, thank you so much. Yep, can everyone hear me? Okay. How about now? No? All right, this is better, okay. Just a sidebar about that baseball game, I'll just say, it was 5.5 hours long. It was about 90 degrees, and I don't think the British people enjoyed it very much. Although they do watch days of cricket, so, but anyway, so I'm here to talk a little bit about what do you do if you are not Medicaid eligible? Looking at in-home services through the lens of a Medicare Advantage member. There are a number of no, that's okay. Good. Okay. There we go. So, as a Medicare Advantage company, we look at different opportunities. How can we think outside the box to give people access to benefits that can help them stay in the home as long as it is feasibly reasonable for them? And through the opportunity that's afforded to us as a Medicare Advantage plan through supplemental benefits, we are able to look at health not just through traditional medical benefits, but also looking at it through the lens of trying to tackle SDOH barriers. That's something that 10, 15 years ago would not have been a part of a Medicare Advantage plan, but now we do have these opportunities. So today I'm just going to give you a couple of quick examples of things that we're doing at CDPHP that we think is pretty unique and effective through benefits. And then also I just want to highlight a community partner that we're working with that's been doing a fantastic job of serving some residents in Saratoga County. So firstly, I just want to address when someone is inpatient in the hospital, that really is when they are probably at their most vulnerable, right? Whether it was planned or it was an emergency admission, they need help. We have partnered with a number of local hospitals, including Albany Med and St. Peter's, where we have actually embedded a patient care team. Our staff will sit down bedside with our members and talk with them and their family and their caregivers about what are their next steps as they transition into home. So do they have the prescriptions that they now need to start taking? Do they have doctor's appointments followed up and scheduled? Do they have transportation to those appointments? And then most importantly, do they have access to food? Depending on how long they have been in the hospital, they may not have food that is available in the home. They may not have the ability to get to the grocery store. They may not have the mobility to prepare their food. So we work with a company called Mom's Meals, where we will dispatch 14 frozen meals upon discharge to ensure that food is not a concern. They have 7 days worth of healthy, nutritious food that they can access and really focus their efforts on those follow-up appointments and really just the process of healing and not be worried about something as basic but as serious as food. Landmark Health is a program we've had in place since 2015. This is a very innovative program, I think. You don't see a lot of this. It's starting to pop up more and more, but this is for our most frail and vulnerable members. These are people typically with 6 or more chronic conditions. They oftentimes have difficulty getting to a doctor's appointment, and it may not necessarily be transportation. Perhaps it is just, a lot of times it's COPD. It's difficulty getting out of the home in general. This is not a replacement of primary care or specialty services, but it is a wraparound to that. So every member that is engaged in this program has a very comprehensive care team that is available to them. It is inclusive of doctors, nurse practitioners, social workers, behavioral health, and even dietitians. They will act as a triage for the member to assess what are the appropriate next steps based on whatever condition they are or situation they are experiencing. So we always tell our members in this program, call Landmark first. Whether it's during the day, it's in the evening, they will triage. So if you need to get to your primary care doctor, they will make sure that you get there. If it's something that they can handle, they will go into the home. They will help them over the phone. We have been able to help our members avoid costly ambulance utilization and emergency room visits by instead accessing this no-cost benefit that is available to them. PAPA is a program that we've had for the last 3 years. It is a company that was founded really on the premise of addressing social isolation and loneliness. There's a great story about how it started. It was essentially a young man who, his grandfather had been diagnosed with dementia. He was just starting to show signs. He was very concerned about him, and so he started taking out ads in his college newspaper, trying to find friends who would be willing to go and sit with his grandfather, his papa. And so from that this company was born. The target of this program is to address something that is not easily identifiable, right? Our claims data does not tell us necessarily that someone is isolated or they feel lonely. That's really something someone has to assess on their own. As you can see, if someone does feel isolated, they are much more susceptible to a number of different medical conditions: stroke, cardiovascular disease, dementia. And as you can also see, right now, 1 in 4 older adults identifies as being lonely or isolated. This population has been impacted probably more so than any other generation by the pandemic. It was really hard for them to come out of it, and they became very, very secure in their home and very hesitant to come back out. And so PAPA has been a way that we can engage these members. This is a wide array of services that PAPA offers to our members. So all of our Medicare Advantage members are offered 30 hours of PAPA support at no cost. They also have the ability, if they go through these hours and they want to continue to use the program, they can purchase hours at a reduced rate if they would like to continue. It can be, their primary target is companionship, but it can also be tech support. Somebody wants to open up a Facebook account. They don't even have an email, but they want to connect with their grandchildren or their children. We've gone into the home and helped them do that. It could be helping with meal prep. It could be helping with light housekeeping. It could also be transportation. And it doesn't need to be transportation to a medical appointment. It could be, I need to get to the grocery store, the bank. I want to get together at the senior center on Tuesday morning to play bridge with my friends. It can really be used for a wide array of services. And again, really just trying to tackle the mental challenges that people may be facing that are not traditionally going to be dealt with in a medical setting. The last thing I just wanted to mention is the Saratoga Senior Life Transitions Program. I know Phil is here. I've seen him walking around. Phil DeSorbo created this program coming out of Saratoga Senior Center, and he started it as a small pilot, and it's really grown and blossomed. And we have joined in partnership with him to help fund this because we really see this as a very innovative way that we can come together as community partners to address these challenges that our members are facing. So Phil has a large number of volunteers that they train, and they really view themselves as an extension of primary care services. They will go into the homes. A lot of their referrals come from provider groups. It could come from the hospital, the health plan, or it could even be a self-referral. They will do an end-to-end assessment with that member to really see what are their gaps, what do they need access to. And then Phil will come back to us as the health plan and coordinate with our care management team to say, okay, what kind of benefits are available to them through their health plan that perhaps they're not aware of or they haven't accessed yet? How do we open that door for them? If it's something that we can't handle, they have established strong relationships with other community-based organizations that these folks may not be aware of. And again, triaging to get them access to the services that they need. I mentioned to Phil I was going to talk about this. I asked him for some examples, and he sent me quite a few of them. Unfortunately, I didn't have the time to get them all in here, but it was truly touching to read these stories and these testaments from people who over and over again, the theme was the same: you have changed my life. You have opened doors for me. And these are the types of collaborations that we believe in and we believe are the foundation of how we as a community work together to ensure that our members are being cared for and that they are living the lives that they want to live. We truly believe that healthcare is local, and these types of partnerships are what's going to help that move forward. So, thank you. Oh, sure. We do offer a dental benefit with our Medicare Advantage plans. And so I will say one unique thing about the way that we are doing dental is I know it's a struggle across all lines of business, right? Dentists are largely stopping accepting of insurance. And you see that more definitely with Medicaid, and we're seeing it very frequently with Medicare as well. So we have an open access benefit. Their dollars are preloaded on a MasterCard, and they can go to any dentist. They do not have to validate a network. We wanted to remove that obstacle for people because when we had a network, so many people were having access issues. And so you literally just go in, you swipe the card, it's like a debit card, it just deducts from it automatically. And once you've depleted it, then you would pay for the service. But most of our plans have at least $1,000 on there for a year. So certainly you can have your preventive cleanings covered with that. Okay, thanks.
Sorry, I threw her that question as a curveball, given what we had discussed earlier, so I thought that was important. So, I mean, first thing to note is get what you're paying for already, right? Through Medicare, there are, not really long-term care services there, but there are lots of services that can assist somebody, and they're paying for them, they're coming out of a hospital, great things. So, but then we need to move on to the next step, and Valerie's going to talk to us about that.
Okay, hello again. I just want to share some tips on getting services. So let's say you're someone who needs home care and the person qualifies for Medicaid. So I think I reviewed this before, that there's a fast track of seeking immediate needs services. So think about that. There's links, I believe there's an appendix in your materials with links to our articles online that really give you chapter and verse of how to apply for that. And the states just made it a little faster with this new directive. So that's one tip. And that's for applying for Medicaid and for home care, all in one batch. So, it's a great system. It is slower now because of staff shortages, but it's still better. Whether you do immediate need or whether you are applying for Medicaid and then going through the New York Independent Assessor to enroll in MLTC, there's always a suggestion not to have the older person or person with disability do that assessment alone. Someone should be with them who knows their needs. Because I don't know about you, but my mom wasn't proud to tell somebody, I'm incontinent. I can't get to the bathroom. This is not what she wanted to tell someone. So someone else has to be there to point these realities out. And one of the realities is the need for verbal cueing. I think what we see is that people are miscoded as independent when, someone with dementia, they might still be continent, but that doesn't mean the person remembers how to clean herself after using the toilet. We learn these things when we're little, but with a cognitive impairment, you forget how. Same thing with holding a fork and spoon. So to really think about each activity of daily living and think, well, what help does that person need? If it's verbal, and it's supervisory, that counts too. Now, it's going to be a problem once those ADL restrictions go into effect, but they're not in effect yet. And for now, you want to stress that need. The other thing I suggested before is that in those 3 days before the assessment, make sure someone's there. For one thing, you're observing. If you're the caregiver, you're observing, and you'll be fresh to be able to report at the assessment exactly what mom can and cannot do. But you're also there to testify that this person needs help and received help in these activities. So that's important. Now, we have a lot of people, most people are coming to NYLAG for help getting an increase in hours. They're already in an MLTC plan. Someone like Stan, right? They're in a plan, they didn't get enough hours, so you're asking for an increase. When someone needs 24-hour care, the state has given us a great guideline. The regulations define exactly what standards you have to meet. You have to need assistance by more than one aid. If the person needs help with, at the very top, toileting, walking, transferring, turning, or positioning. Oh, okay. So you're going to go through those ADLs. Which one of those do you need help with? And can the aide get 5 hours of sleep at night or not? So there's you don't have to be a lawyer to be able to read that definition and go through, your client, your parent, your adult child with the disability, and say, well, let's see, do you meet these standards? And have someone if someone's providing care at night, have them keep a log. That way you see, oh, you're not getting 5 hours of sleep. Okay, you qualify for split shift. So the state gives that nice template. When you ask for more hours, do it in writing. You can ask for it orally, like with the nurse, but then follow up and confirm it in writing. I'm a lawyer, I like to write things, okay? Even if you're not, just confirm it because it matters. What was that?
Evidence. You need evidence that you did these things.
That's
So
right.
verbal isn't going to do you any good.
That's right. You need that evidence. And you're being concrete. One of the things you're clarifying in writing is what can family do? When family help, it's supposed to be voluntary. And the plans and the local agencies assume that just because you have a daughter, she's there and she can help. Well, that daughter's got to make clear, I work, I have 2 children I take care of, I got to get them to bed. I can help overnight, or I can't help overnight. I can help on weekends, or I can't help. Be clear. That's absolutely, and it should be in writing. Okay. When you're requesting less than 24-hour care, the guideposts are not as clear, but the state has a wonderful policy that if you do this work, you should have on your desktop. It's MLTC policy 1607. It's here. It's very clear. It says, does the person have scheduled needs, or do they arise at unpredictable times? Are they recurring? These are all things you can go through, and these are the building blocks of building a case. With safety monitoring, this is something we hear from plans and also local DSS, HRA. We don't do safety monitoring. Well, you know what? Safety monitoring is a term that's overused. But what they do, and the state directive says it, is that they do provide supervision and prompting to enable someone to do ADL safely. That's to help someone go to the bathroom safely, walk safely. That's not safety monitoring. That's bona fide legitimate assistance. So don't let them sort of, cast everything with that gauze of safety monitoring, but you have to be very specific about which ADL or IADL, those are the housekeeping tasks, the person needs help with to perform safely. There's a whole appeals process. Let's assume you appealed, you lost, most people do, sometimes you win. You request a fair hearing, and on this, I want to give you a tip that the state's hearing request system asks, is the person homebound? And you want to, if the client, I think the definition's on the next slide. So if the client is homebound, you want to indicate that. You don't have to request a hearing at all if the client's in a Medicaid Advantage Plus plan. And that's a merger of a Medicare Advantage plan with an MLTC plan, all in one. You don't have to request a hearing. It's automatically requested. It's a unique system. But so here's the definition of homebound status. Because of a mental or physical disability, they cannot travel to a fair hearing without substantial hardship. Okay? That's not that hard to meet if, you know, for clients who are seeking home care. Now, because of an injunction in a case called Varshavsky that's over 30 years old, it was my first lawsuit in the 90s. I'm very proud of this, is my legacy, Varshavsky, thank you. The judge, at a hearing where someone's been marked homebound, in that first initial phone hearing, because they're all held by phone now because of COVID, the judge is not allowed to make a losing decision for you. You can't lose that decision because you're homebound and the hearing's by phone. And the injunction says you should have a crack at having that hearing held again at your home with an ALJ to see you, because you could not travel to the hearings even if they were being held on site. So because of that, the hearing is scheduled, or it's put in a pile to be scheduled someday for part 2 in your home. And they actually are starting to do these now. And because there's such delays in holding those, OTDA, the state's Fair Hearing Office, will order the plan or HRA or your local district, whoever it is, to increase the hours that you were asking for in the hearing to the amount you requested 45 days after the fair hearing is requested. So it's sort of like a temporary restraining order. Like they said, okay, we know you're appealing this. It doesn't mean you won. It means you will get the increased hours, at least temporarily, until your hearing is held at home through a home hearing. So because of that, I know Stan was out of pocket for 8 months, but people should only be, and it can take 8 months to get through the whole MLTC increase and all that, but at least once you get to the fair hearing stage, you should only be out of pocket for 45 days, and then the amount you requested should kick in. So that's a really important tip. However, if you're in a Medicaid Advantage Plus plan, that doesn't apply. There's no Varshavsky interim aid. You don't get it. The state's policy is you don't get it. We think that's wrong, but that's what they say. So you have to make sure you know what kind of plan you're in. Most people are in the regular MLTC plan, so they get this relief. And there's tips there on how to do it. Just want to tell you, there's another way of appealing. Let's say you can't, that 45 days is too much for your client. There's something called an external appeal. Those can be decided in as little as 3 days after you file it. Now, it takes a week to prepare the papers. It's a lot of work. But once you do it, if it's expedited, and you need the client's physician to sign the paper, it needs to be expedited. It's, again, a lot of work. But if your client's really desperate and doesn't have someone who can pay, for, they can't pay out of pocket for 45 days, this is really something to think about. Again, complaint numbers, and those are my suggestions.
So we've been at this for a while, and there's some things I've learned over time, and just to reinforce some of the things that Valerie said. You don't live to be very old unless you're stubborn. So Stubborn people live longer, 100%. And if you're stubborn and miserable, buckle up, because it's going to be a long ride. So you're going to need to make that clear. Someone needs to be there during that assessment to say that what's actually happening. And it's also true that they assume that family help is going to be available. Their daughter's there. Their daughter says, I have 2 kids and a husband, so I essentially have 3 children, right? I can help here too. So we need to be cognizant of those things. So, but as much as we have maybe not been as nice to the plans, from a plan perspective, I don't think they're Scrooge McDuck jumping in their money bin at night either. And we need to have some fairness and have Andrew give us that.
Okay, thank you. So Valerie and I go back 40 years, Valerie, actually more than 40, but we just reconnected and realized that we're both born on the same day, the same year. So that is incredible. I wanted to share that with people. So I'm Andrew Koski with the Home Care Association. We represent home care providers, hospice providers, and managed long-term care plans, and also some mainstream plans. So I'll be talking a little bit about the perspective from the providers and what we're up against. But before I do that, I want to just talk a little bit about home care, because I assume that everybody knows what home care is, but having worked in the field for many years, I don't think everybody knows what it is. And I think a lot of us are very familiar with personal care, people that require assistance with activities of daily living. You know, you fall, you're in the hospital, you come home, you need help with the activities of daily living, and that's definitely very important. Personal care, my mom had it twice after some stays in the hospital. And consumer directed, we'll be talking next, which is also very important, includes personal care, but also skilled care. So home health care, and I just want to emphasize that home health care, it ranges from clinically complex professional nursing and therapy services to long-term care support services for the chronically ill. The care continuum is health care at home. It includes a range of medical, social, assistive, and other services provided in an individual's home following a hospital stay, or even not following a hospital stay. It's provided by nurses, therapists, home health aides, and other direct care staff under the direction of a physician's order. And the focus of this includes prevention, recuperation, and alternative to higher-end institutional care. And patients receiving home health care include newborns and mothers eligible for maternal infant care services, young children and adults in need of at-home therapy or advanced technology-based care and support. And again, I think a lot of it that is lost in the whole discussion on home care. So home health care is delivered by certified home health agencies known as CHAs. We have a bunch of CHAs here today. Licensed home care services agencies. We have licensed agencies in the audience, also out at some of the booths. And again, they're reimbursed by Medicare, Medicaid, managed care, and commercial insurance. Personal care, again, we pretty much have discussed that today. I'm not going to go over that. Our next speaker will get into consumer directed. Hospice, I'm not sure if we discussed that today, but it's for people who are terminally ill, and rather than treatment, it focuses on easing symptoms at the end of life. And then care management, of course, is a component to all the services being provided, whether it's through the state, through Medicaid, or through the State Office for the Aging. The financing, well, Medicare, traditional Medicare, Medicare Advantage, and I must say that I'm a member of CDPHP, my Medicare Advantage plan, and even though I read that handbook the 100 pages through, I learned some new benefits today, so I really appreciate that, particularly the long-term care benefits. Medicaid, traditional Medicaid, Medicaid managed care, private insurance, again, commercial insurance, long-term care, and then others, ISEP, expanded in-home services for the elderly program, Veterans Administration, self or private pay, workers' compensation, and of course, we went over insurance. So every year, the Home Care Association of New York State does a State of the Industry report. So we look at the Medicaid cost report data, home health and hospice statistical report data, state and federal labor statistics, and then we survey our members on different issues related to their operations. And you can actually use this stamp at the bottom to get the report. It's very interactive, so we don't usually send out a PDF version because you can actually learn a lot from the report. I have to credit Ariana Stone, who's in the audience, who actually developed the survey. She handled reviewing the findings and then actually put it into simple language. So Ariana, thank you so much for that. So what do we find in our report? And again, this is based on the data from the state. So 20% of CHAs, this is the survey respondents, not 20% of all CHAs. 20% of survey respondents opened a line of credit or used reserves or investment to pay for operating expenses in 2022. 32% of the licensed agencies opened a line of credit, 18% used reserves or investments. 29% of hospice survey respondents opened a line of credit, and 14% used reserves or investments. 1/3 of the plans used reserves or investments to pay for operating expenses, and then 42% of the FIs, we have FI members also, opened a line of credit, and 25% used reserves or investments. Now, why is that important to know? And you'll see when I discuss operating margins. Obviously, New York State has the most comprehensive Medicaid benefit. We have great, ISEP program and other sort of, as Greg would say, siloed programs when it comes to home and community-based services. And it's great, but there's always an issue of access. If you don't have the staff, you don't have the nurses, the therapists, the aides, personal care aides, home health aides, then you may not get what you're eligible for. And those of us who, well, I used to live in New York City, so I was familiar with New York City and the home care hours that they get, and then I move up here and I could not believe the difference. So it really does vary on a geographical basis. And that's why it's important to sort of understand where the industry is. Now, how about operating margins? So 57% of hospices had a negative operating margin in 2020. 52% of CHAs had a negative operating margin in 2021. 38% of LICSs had a negative operating margin. 33% of PACE plans had a negative operating margin. And then about 22% of CDPAP fiscal intermediaries had a negative operating margin. So again, you can see that this does affect, delivering services. What do we find? No surprise, wage and benefits, staff turnover and recruitment are among the highest factors affecting increased costs for all CHAs, licensed agencies, and hospices. And then wages and benefits are the highest factors increasing costs for CDPAP and FIs. What about when it comes to the workforce? So paperwork and regulatory burden, staff finding higher pay elsewhere, and staff burnout are the top factors impacting turnover rates for all CHAs, licensed agencies, and hospices. 31% of all PCAs or personal care aides, 22% of all home health aides, and 25% of all RN positions are currently unfilled. I mean, that's incredible. I was downstate yesterday at a meeting in Dutchess County, and I ran into one of our CHA members, works out of a hospital, and she said, we have had 7 unfilled nursing positions for 2 years. We just filled 2 of them. So again, that does affect, obviously taking cases. Home health aides have an average turnover rate, and again, this is based on the survey results. This is not, based on data from the state. Average turnover rate of 26% of all home care providers, PCAs, 33% turnover rate. On average, 17% of cases per agency per month are delayed in initiating the start of care among all home care providers. And then on average, 15% of cases per agency per month are denied primarily due to labor shortages among all home care providers. So again, this is what we're facing. Now, having worked with consumers for many years, I would never say that this should then cloud, if you're not getting the services you need, you have to fight to get those services and exercise your appeal rights. But again, just want to know what's happening from the provider perspective. So what are the things that need to be done? And I'm sure this was discussed early and raised with our elected officials. Ensure adequate funding for home and community-based services. This year's budget had extra money for nursing homes, hospitals, assisted living, and I'm sure they all need it. And we have members that do serve those areas, but there was nothing, again, for home health or personal care or FI services. We need to enhance patient quality and access to services. We have to foster and continue partnerships and collaboration across the healthcare continuum, encourage and provide funding for technology, research, and data. Whenever I hear Greg talk about what you guys are doing with technology, I'm just blown away. I just can't believe it. But our members do need funding, and a lot of it is for electronic health records, telehealth, and then again, you mentioned a lot of other things they can and should be doing. And of course, invest in training and career advancement. That's so important. Okay. Thank you very much. My contact information is here. Ariana Stone, who worked on this report, is here. And again, if you have questions about any of this, feel free to contact us. Thank you.
All right, so I think so far the overall message is it's going great, okay? We can't get some hours, we can't get staffed, we can't have agencies that are probably even gonna survive. We can't operate on a negative margin for very long. So this is what we're gonna do as a state. We are going to take away the program where you find your own aides, or we're gonna make it much more difficult to access. So this is a great idea, but to kind of get into that, Andrew.
Thanks, Aaron. All right, so CDPAP. We haven't talked about this at all today, right? All right, so Valerie did a fantastic job giving an overview earlier of the recent New York State budget implications to CDPAP. So I'll give a brief overview and then talk about some non-Medicaid consumer direct models. So skip ahead. So the single statewide FI. Currently, we don't really know an exact number, but there's estimated to be between 600 and 700 fiscal intermediaries in New York State, right? So this proposal that was in the New York State budget essentially eliminates these fiscal intermediaries and moves towards one entity that would be providing CDPAP services statewide. So the requirements for that are that they must have the capability to provide statewide services, demonstrated cultural and language competencies, proven experience serving individuals with disabilities, right? Because the program was initially started by individuals with disabilities for individuals with disabilities, and has provided FI services statewide. There we go. In at least one other state on or before April 1st of 2024. So what the intent of this was to find a fiscal intermediary that is operating out of New York State, providing FI services statewide, has a contract with that state. So based on what we know, currently in New York State, with the fiscal intermediaries that are operating, there are either very few or none that would be eligible to apply for this single FI entity. The structure, the single statewide FI would contract with the managed plans, the MLTCs, the local DSS to provide services, and there is a provision included for subcontracting. So we don't quite know what that is. There was a lot of really vague and ambiguous language in the statute, but if we go, so here are the FI responsibilities. We assume that with this new single statewide FI, that the statewide FI would take on wage and benefits and contracting and billing to the plans. This would leave health assessments, maintaining personal assistance records, onboarding orientation, consumer records, and some compliance to the subcontractors. So to be eligible to be a subcontractor, you must be a independent living center operating services since at least January 1st of 2024, or a fiscal intermediary providing services since January 1st of 2012. Well, why did they come up with 2012? So 2012 was prior to the MLTCs taking over the management of the CDPAP program. Before 2012, it was on a fee-for-service model operated by DOH. So once the MLTCs did take over the management, the amount of FIs providing CDPAP services grew substantially. So the structure would be that there would be at least one ILC included. As Valerie mentioned, the language there is an entity. We think that it was the intent of the legislatures to include all 11 ILCs that are providing FI services in New York State. And then a minimum of one other FI per DOH rate setting region. So we believe there's 4, downstate, Hudson Valley, upstate, Metro, and the rest of the state. At least 5 subcontractors, or a minimum of 5. Really, the discretion's up to the single statewide FI to how many there would be. Really the role of the subcontractors as well. So what's next? So as I mentioned, and Valerie touched on as well, the statute had a lot of language that leads us to speculation. So what we're looking for is the request for proposal around the single statewide FI, which should be out in the next 2 to 3 months, which really should provide us that additional detail around the single FI, around the subcontracting process, and even the transition process. So once that RFP is released, then there will be a minimum of 60 days for those entities to respond. And then DOH has 60 days to assess, score, and award a single contract to that FI. So once the contract has been awarded to that single FI, then we can start the transition process, right? So that would be the selection of the subcontractors, the contracting with the plans, the notification to consumers and existing FIs of a transition plan, and then successfully transitioning 250,000 consumers to a single statewide FI, which is a massive undertaking. I know I liked Valerie's expressions much better about this, but it's challenging. And the piece that's in the statute is that essentially any FI that is not selected as a subcontractor or the single statewide FI must cease providing FI services as of April 1st, 2025. So that means that all of this needs to be implemented in 10 or 11 months, which, as all of us know, is quite challenging and quite unrealistic as well. And if it's not done properly, if it's rushed, there's most certainly going to be a disruption of services to our consumers. And if it's not implemented by April 1st of 2025, then it also is not going to achieve the savings that the budget stated it would achieve by doing this. So more to come on this. If this is a topic that really interests you, certainly keep an eye out for that RFP. And then lastly, I just wanted to touch on some non-Medicaid consumer direct models for home care. When we think about consumer-directed personal assistance, we immediately think Medicaid. Well, there are some other ones as well. So we do have ISEP, Expanded In-Home Services for the Elderly program. There are many, it's operated by the local offices for aging, and there are many OFAs within New York State that do have a consumer direct model for ISEP. Specifically in the capital region, Albany and Schenectady counties do have a consumer direct model. The OFAs also provide family caregiver respite on a much smaller scale, but if they do have a consumer direct model for ISEP, then they can provide this service that way as well. There's also the Alzheimer's Caregiver Support Initiative. So this is a DOH initiative to provide support to caregivers of individuals with Alzheimer's disease or related dementias. A big piece of this program is respite in the form of in-home care. So locally in the capital region, we have Eddie Alzheimer's Services. They're the lead contractor, and they do have a consumer-directed respite model. And then downstate, we do have Alzheimer's Association of the Hudson Valley, also has a consumer-directed respite model. Now, Andrew was talking about the VA, and that made me think. The VA also has a consumer-direct model. And then lastly, there's private pay consumer-directed personal assistance. So it doesn't currently exist on a large scale. We believe there's one organization in Western New York that actually does provide this service. But we at Consumer-Directed Choices plan to open this business line in the fall. We think it would be great for the community as well as those individuals that may be Medicaid eligible but have a spend down, as this would count towards their spend down. So if this is a service that interests you, certainly stop by our table when you get a chance. Thanks.
Well, so hastily drafted legislation that's vague and ambiguous. I don't know, that sounds great to me as a lawyer because I think there's going to be some ground there. So we'll see what happens. But It's now lunchtime, best news of the day. But we do have time for questions if people would like questions.
Question I have, the single FI, is that gonna comply with Title II of the ADA and make the programs and services and activities compliant so that the state makes sure that they be in compliant with the American with Disabilities Act?
That's a great question, and we don't know the answer yet, but it should, right? It has to comply with the ADA, but it's a great question of how it will do that, right? And not to mention, the requirements for language capacity and cultural competency and disability competency. Great question, no answers.
One quick comment with respect to what you were saying, Andrew, on the FIs needing some contract with existing FIs by rate-setting areas. To add another layer of complexity to what is already complex, especially that rest of state category that was on your slide, that is made up of non-contiguous counties spread all over the state, leading to the question, how much is this supposed to save?
Great point. Thank you.
For Alicia. So the other panelists were talking a lot about, there's tremendous demand going this way, supply of providers is this way. You've got some great programs in place now. What's sort of the next step to, maintain, not have costs go up, but your satisfaction go down? Seems like to be quite the challenge. Love to know what you're thinking.
Yeah, that's a great question. It's something we grapple with every year. We are right now in the process of building and designing products for 2025. There are significant changes coming to Medicare Advantage in 2025 if you're not read up on that. The Part D benefit, which was first implemented in 2006, has been completely overhauled starting in 2025, which is fantastic for consumers. We're essentially taking what is currently a maximum out of pocket of almost $8,000 that someone may spend on Part D prescription drugs down to $2,000. So that is fantastic, but those dollars that are spent don't just go away, right? So the cost of that change is coming back to the health plans. We're not getting additional reimbursement really from the federal government to help support that on a large scale. So I think if you read the industry papers and you've been paying attention, the nationals are talking a lot about cutting back supplemental benefits, pulling out of service areas. We're seeing a lot of disruption with the provider networks. I know there's been a lot of people talking today. St. Peter's had just announced a termination with a national carrier for July 1st. So I think what we're going to see truly is providers working more closely with local regional players because we are a part of this community, right? And so we don't have plans all over the country. We service plans in 33 counties in upstate New York. This is our home and this is our focus. And so we are very laser focused right now on trying to figure out how do we make the most of the dollars that are available to us to continue to offer not only mainstream medical benefits, but continue to offer the critical supplemental benefits that people really need because they are life-changing for them. And so we're working through that right now, but every year it very much is a challenge.
Thank you. I'm a social worker. I work for a palliative care program affiliated with Hudson Valley Hospice. So I go into a lot of people's homes in the community and I try to help them navigate these systems and walk them through the MLTC process, et cetera. Kind of a simple question. What's the best way to guide folks towards which MLTC would be best for them? I always kind of feel like I run into a wall at that part of the process because there seems like there's a lot, but they kind of all seem the same, but maybe they're not.
I know on our end, that's where we kind of involve a geriatric social worker, who's interfacing with these plans and providers all the time, because in some counties, there aren't really many choices. In other counties, there are a lot of choices, but sometimes the one with the best name is not the one you really want to pick. So there's really a lot of local knowledge to that, and I think that's probably your best resource.
Hi, I could just have a response there too. If someone has an aide through maybe their county before they're transitioning to MLTC, usually they develop a relationship with them and they want to keep them. So one thing to do is ask the aide's employer, that licensed home care service agency, which MLTC plans do you contract with? And then that way they can, keep that aide. And that's a priority for people. Or if they go to an adult daycare program, they want to make sure it's in the network. But the other factor that people really have is the hours of care. So, generally there is a shopping, the state set this system up so that it's competitive and there's consumer choice. And what we see is people contacting a number of plans and saying, okay, how many hours are you going to give me? And they go with the best one. And that's sort of keeping your aid and maximizing hours are the two main factors.
Yeah, we use a lot of CDPAP to keep the aid too, but I don't know going forward if that's going to be the same or not.
Good day, I'm Peter Strauss. On the train up yesterday morning, I read a very fascinating article in the New York Times on the question of whether two persons who are persons with disabilities fit into all these programs and whether or not they should marry. And you all represent different aspects of the delivery of services, and it's a very complicated question, but I thought I wanted to call that article to the attention of the audience here and abroad, and whether you have any sense about, is this a subset of our mutual clients that is being left out?
I mean, we have on occasion advised long-term couples to get married because they had better protections under Medicaid eligibility for that purpose. We have also had situations where both spouses needed assistance, and together we could get them 24/7 assistance because they both had significant needs. That worked out really well, but then you have a problem because almost every time one is going to pass on before the other. So then we have to kind of get into a mode to argue about hours, but lots of times we've been able to really buttress the care by having both of them on medication.
Hi, this may need to be answered offline, but in regards to MLTCs, individuals who are on an MLTC can access hospice services from being on an MLTC, but if they're not in the MLTC, they're not allowed to enroll in the MLTC and be on hospice. It's this and so what happens is they have to be discharged from the hospice, lose all their services, and wait for the enrollment to the MLTC to get the long-term care supports that they need. I would like to advocate for a change in that, but I don't know where that lives in statute, in, just OHIP policy, and would love some advice. Thank you.
Yeah, I can take that. I think I'm not sure if it's a state policy or if it's in the 1115 waiver that governs it, but at any rate, it's state policy. But don't forget, if you're in home hospice, so you're right, you can't go get into an MLTC, but you can apply to your local Medicaid agency, your county, for standalone personal care or CDPAP services. And if it's urgent, as it is for many hospice enrollees, you can do it through the immediate need process, which is faster. So it's, you know, there are options outside of MLTC. I mean, for anyone who's not eligible for MLTC, they can generally enroll with their county.
Valerie, can I just, Green County be flattened, before we got down to red regs? Problem with the local district, and I am the local district, is that the regs state that we cannot put in services if hospice is in fact already started, unless the services were in place beforehand for things not related to the reason the person is on hospice. That's what the regs say.
I don't think so. I mean, I guess we could talk about this offline, but I've never seen that in the, I know the regs pretty well. I've never seen that.
And we are full advocates of having services in place and then having hospice come on board. But the problem is, if hospice is in for the diagnosis, we cannot put services in based on incapacities related to that diagnosis.
Okay, well, I guess we have to just disagree on that, and I'm glad to correspond with you to get that.
Yeah.
Just. I actually like the guidance on that, because every time we go to enroll somebody in either NHG or NLPC, and we want to add hospice, to this point, the diagnosis has to be different. No program in the 3 regions I work in allow somebody to have the same diagnosis for both programs.
We face this, Valerie, frequently with clients coming in and they, oh, I'm gonna go on hospice, and they get 2 hours a day of hands-on care 3 days a week, or maybe 1 hour, and they need 24/7 care, and they get denied Medicaid because of the hospice services. We have been able to fight that, but I do believe that the regulations and what the counties are being told is that they cannot provide service if hospice is already in place for the same diagnosis.
Even for 1 hour.
Right.
Hi,
Categorically ineligible for Medicaid.
Can I comment on that? Yeah, hi, I'm Sim Goldman. A lot of you know me. Several years ago, it was about 10 years ago, there were several cases upstate where the counties were denying people who were already receiving home care, because they received hospice. They were claiming it was duplicating services. I took 2 of them to fair hearing, and in both instances we were successful. You shouldn't have to take these cases to fair hearing, but you should know that there's just no way what you described could possibly be consistent with the regulations, is what Valerie said. Thank you.